Historically, flexibility has been addressed in an isolated manner, muscle by muscle. This has been effective, however, does not address the key movement relationships necessary for efficient movement. Flexibility Highways investigates the fascial system and how it functions to create efficient and economical reactions within the body. This module will explore the relationships that exist within the body to promote integrated flexibility and enhanced performance. Flexibility Highways will examine the 6 integrated chain relationships that is dependent upon the partnership of adjacent muscle groups to attain optimal function and performance. Flexibility Highways in Motion matches movement pattern progressions that enhance the proprioceptors of the soft tissue to maintain strength within each of the 6 flexibility highways and enrich movement performance. The following passages are from Anatomy Train 2nd edition by Thomas Myers. This is a resource I highly suggest. The traditional mechanistic view of anatomy, as useful as it has been, has objectified rather than humanized our relationships to our insides. This passage refers to the traditional approach to the study of anatomy, that being in isolation. We need to understand what the tissue does in isolated action and where it attaches to its origin and insertion. However, the student must keep in mind this approach is isolated, concentric contraction in nature, and dominant in one plane of motion. This is actually opposite of how the body works. In triplane integrated reactions, the body movement has the following characteristics. It's integrated, it's eccentric loading first, and all muscles and all joints work in 3 planes of motion. Whatever else they may be doing individually, muscles also influence functionally integrated body-wide continuities within fascial webbing. This integrated body-wide tensional network allows a transfer and mitigation of forces throughout the system, allowing for more economical and efficient actions to be distributed, reducing overuse and stress to a local region. Therefore, the tissues within the body have impact upon the rest of the body. This beautiful video clip is from Interior Architectures, Exploring the Architecture of the Human Body by Dr. Jean-Claude Guillemberto. Tensegrity, tensional integrity, or floating compression is a structural principle based upon the use of isolated components in compression inside a net of continuous tension in such a way that the compressed members, that being the bones in the body, do not really touch each other, and in the pre-stretched tensioned members, usually the ligaments, tendons, and connective tissue, they delineate the system spatially. The fascial webbing is an example of the integrity model within the body. The triangulation of the fascial structure assists to connect tissue within the body to create a synergistic system to absorb forces and also transfer forces to provide an efficient network to maintain the deformation the tissues undergo when performing useful, efficient work. Tensegrity is the balance between tension and compression, between push and pull. Notice in this photo how the struts never touch but assist to maintain the spacing between each strut. Also notice how the cables help suspend the struts, and as the cables shorten, others will lengthen to compress and spread tension throughout the system. This photo shows how the tensegrity system can maintain structure of the spine-like looking model. Now observe the similarities of the spine, its structural tensegrity and triangulation. Triangles are sturdy structures and will maintain its relative shape by compressing on one side and tensioning on another. When viewing the muscular architecture of the back, take note of the triangulation of the soft tissue, all designed to mitigate and transfer forces while maintaining its structure. In the next 3 slides, take a look to see the spatial integrity of the triangulated fascial arrangement within and among the soft tissue. This is all designed for force absorption and transfer for an efficient, synergistic efficiency of movement. There are universal connections that are system-wide within the fascial matrix. First, one of the primary functions of fascia is to maintain cellular spacing. The tensegrity model demonstrates that the struts or the bones maintain the structural spacing for optimal loading and mitigation of forces upon the tissues and structures. This is also found within the microfilaments of the entire muscle bundle. By maintaining cellular spacing, the body has a mechanical advantage to distribute forces most efficiently, as well as absorb forces throughout the entire system. Reticulin, which is immature collagen, is gradually replaced by collagen produced by mesodermal fibroblasts comprising the sticky extracellular matrix. Did you ever wonder why infants and young children are so flexible? That is due to the immature collagen called reticulin, which is very pliable yet maintains structure. As the child matures into a fully developed being, the reticulin is replaced by collagen that is comprised of the sticky extracellular matrix, a gel-like substance that nourishes and lubricates the tissues so that they will slide and glide upon each other. Inefficient movements, injury limitations, and joint actions will add to the abnormal stresses, which will create more extracellular matrix to the region, reducing the stress upon that region, and yet creates immobility of the joints and surrounding tissue. Fascia is stimulated by mechanical loading, that being any stress being placed upon the body, such as body movements, external loads or forces, or just stretching. The fascial system responds to eccentric stresses upon the body to strengthen it. In other words, as we move in three planes of motion, what we have to understand is that the fascial system relies upon eccentric triplane loading to strengthen yet mobilize the myofascial system. Collagen favors mobility. In other words, if the joints and the soft tissues are loaded in three planes of motion from the bottom up as well as the top down, then there is greater likelihood they will remain very mobile. If the tissues are working in three planes of motion and loaded under the weight of the body in three planes of movement, then the tissues are eccentrically loaded and inherently become stronger and more stable. Therefore, the mobility will enhance stability. They are part of the same movement continuum, not on opposite ends of the movement spectrum. Fascia has 9 to 10 times more proprioceptors in fascia versus muscle. Recent research has indicated fascial tissue 9 to 10 times more proprioceptors than muscle tissue. Additionally, the majority of the soft tissue pain derives from the fascia and not muscle tissue as previously thought. Therefore, movement training that eccentrically loads the myofascial system in three planes of motion will improve mobility, enhance stability, and have impacts upon the postures of individuals. Collagen favors mobility, which will result in stability. Triplane movements will strengthen them. Any posture that requires the fascial system structure must load in triplane positions for adaptations. In other words, movement and deformation of the fascia will strengthen the structures. Therefore, these postural changes must be consistent, they must be often, and especially require a triplane movement reaction. This will strengthen the entire system.
Historically, when clients have presented with kyphotic or round-shouldered posture, historically the fitness industry and the physio industry has addressed strictly the thoracic spine. But if you think about this, when we're round-shouldered, there's going to be an entire chain reaction. So what I'd like you to do for a moment is stand tall. From the greater trochanter to the top of your head, reach your head to the ceiling and stand tall. You'll notice that you have your lordosis. So what I'd like you to do is place your hand at your low back and one hand on your pelvis. now become kyphotic. You will notice that as you become kyphotic, you flex at the lumbar spine, you flex at the thoracic spine, your shoulders are protracted, your cervical spine is flexed, and your head has come forward. But one thing as well, if you go from this position, stand tall again, you go from this side, you go from a kyphotic to to a stand tall position, your pelvis goes into a relative anterior pelvic tilt. When we do become kyphotic, you will see the pelvis also goes into a posterior pelvic tilt. So kyphosis is not only affecting the thoracic spine, it's affecting the pelvis as well. Or if you have somebody who has a posterior pelvic tilt, it's also going to flex the lumbar spine and create relative thoracic flexion. Some strategies for this in the past has been just stretch the pec and strengthen the posterior shoulder, but we have not addressed the pelvis. What we really need to do is have your client stand tall. To whatever capability they can, stand tall. From the greater trochanter to the top of your head, reach your head to the ceiling. Next is get into a staggered stance. If you will notice, as you get into a staggered stance, the extended hip now goes into an anterior pelvic tilt. You can then take a band or a tube or a low cable row, start low, stand tall, but reach forward, grab that band, cable, low cable row, and just reach to your hip height posterior side. As you do so, you're going to bend forward again. You're going to get into actually more kyphosis. Reach back, rotate the hip. Remember the beacon of light. Shine the beacon of light into the lead leg. Rotate the hip as you reach posteriorly. What you'll see as you reach posteriorly, you're getting a stretch of the pec, actually getting a stretch of the pec into the opposite hip. And you're also getting retraction of the posterior shoulder girdle. The objective has always been stretch the pecs, strengthen the backside, but we've never addressed the pelvis. Unless if we get the pelvis into a relatively anterior pelvic tilt, you will not gain the lordosis back. So what we're saying here, what we're suggesting is get into a staggered stance, anterior pelvic tilt, reach forward, and reach back. You're going to see that we're able to address the kyphotic posture, but not through the sagittal plane. You're going to gain success through the transverse plane. We stretch the anterior side, and we strengthen the posterior side. We've stretched the anterior X factor and the flexibility highway, and we're strengthening the posterior flexibility highway as well as the posterior X factor on the opposite side. So when we think about this, kyphosis is not just a thoracic problem, it's a pelvic problem as well. And we cannot clean up, we cannot have improvement in the posture unless we address both the thoracic spine as well as the pelvis.
Numerous authors and presenters have proclaimed that the body is a series of alternating joints that are mobile, stable, mobile, stable. At first this seemed logical. However, considering the movement grid, we quickly realized this is not actually the case. When reviewing the movement grid, we learned all muscles and joints work in three planes of motion. It may be true that certain joints have a dominance in a particular plane of motion, but that does not preclude it from not reacting in the other two planes. Review the principles and concepts of the movement grid, and you will quickly see the thought of alternating mobility, stability, joint levels is not the full accounting of movements that truly occur in human function. In the key relationships, there's optimal movements in a series of relationships of adjacent and distal joints and soft tissues. It is important to have an adequate mobility within these regions and also among the regions to achieve optimal movement. When performing movement preparation and flexibility, stretch certain regions together. Historically, stretching has been done in isolation or link action. This approach is effective, but the trainer must keep in mind this is a link action and movement is a series of chain reactions. Stretch the isolated link and then integrate the regions into a chain action by stretching critical distal tissues with other key big movement rocks for optimal performance. Therefore, the following are regions that should be stretched together and motion captured in these critical areas. The great toe and calf. The calf group and the hip flexors. The hip flexors and the abdominals. The abdominals and the pectorals. Hip flexors and opposite shoulder, meaning the anterior X factor. Opposite gluteals and opposite lats, the posterior X factor. And the hamstrings and gluteals all need to be stretched together at some point within the stretching program. The great toe and calf group, they're necessary for ankle dorsiflexion. They're actually required to have optimal knee extension, and they will also enhance hip extension when there is good mobility within the great toe and the calf group. The calf and the hip flexors. The calf affects the hips in all three planes of motion. The gastrocnemius attaches at the femoral condyles, affecting the knee and the distal femoral rotation. In other words, as the calf and the gastroc in particular is eccentrically loaded, it will extend the knee. It will pull the femoral condyles posteriorly, which causes knee extension, which will also enhance hip extension. The shoulder flexion lengthens the proximal abdominal fibers in the sagittal plane. So it is critical that we have good range of motion in the shoulder girdle, which is also going to impact upon the abdominal region. Likewise, tightness in the proximal abdominals can affect shoulder flexion. Hip extension enhances shoulder flexion through the abdominals. In other words, the same side shoulder that can go into flexion will be enhanced by the same side hip that goes into extension.
Whatever your impression is, whatever your perception is of the core, it goes well beyond the abdominals and the hips. I believe the core starts from the floor. In fact, I believe the core starts from the great toe. If we look at this, I believe the absolute friends of the abdominals is the hip flexors, the calf, the great toe, and the shoulder girdle. Because when we walk, we're in this contralateral reach. When you get into this contralateral reach and you have your hip extended, the pelvis goes into anterior pelvic tilt. The pelvis of the extended hip goes into an anterior pelvic tilt, which lengthens the abdominals in the sagittal plane. When we have a contralateral reach, you see that the thoracic spine is rotating one way, the pelvis is going another way. Looking at it straight on, you've got rotation to the right in this case, and the pelvis is rotated to the left, which lengthens the abdominals in all three planes of motion, especially in the transverse plane. Then as you start walking and propel off of your great toe, you get further hip extension, which is further going to load the abdominals in the sagittal plane. But once we get into mid-stance, what we need to do is be able to keep our eyes upright. If we didn't, then this hip hikes, we would be leaning to the opposite side, but our tendency is to keep our eyes and our head level to the ground, which lengthens the abdominals in the frontal plane. So now the abdominals are loaded in all three planes of motion. If you have any limitation in your ankle, if you don't have good dorsiflexion, you will not be able to go through good hip extension, which is then going to limit the ability to load the abdominals in the sagittal plane. But if you don't have good hip extension, that's going to limit your ability to load the abdominals in the transverse plane, which will now shorten the stride, and you're not going to load the abdominals in all three planes of motion, and especially in the last of the frontal plane. So what we need to do is make sure that we have good mobility in the great toe, the calf, and the hip to allow rotation, and good thoracic motion to allow rotation, so we can load the abdominals in all three planes of motion. The absolute friends of the abdominals, the way I look at it as we start from the ground up, is good mobility in the great toe, good motion in the ankle, good mobility in the hip flexors, and good mobility in the thoracic spine, good mobility in the shoulder girdle, because that will load the abdominals in all three planes of motion, and then we've got the absolute friends of the abdominals. Great toe, calf, ankle, hip, thoracic spine. Flexibility Highways is an integrated approach of flexibility from the ground up as well as the top down. Early in my career, when I would study flexibility, we're always looking at the flexibility of a particular muscle. I'm concerned of what the muscle does. I'm concerned where the muscle attaches, but I have more of a concern of the fascial connections that surround the muscle tissue, that connects muscle to bone, that connects muscle to muscle and to adjacent muscles, and provides this longitudinal, latitudinal, and three-dimensional in-depth connection with the tissues that surround the particular muscle. And I believe that the body is connected in really many ways through the myofascial matrix, the inner connecting web that is all around the body that creates synergistic relationships and synergistic efficient movements. But when I look at flexibility, I look at 6 flexibility highways. One is the anterior flexibility highway that runs from the anterior tibialis that comes north and connects with the distal quadricep. The distal quadricep comes up, connects to the hip flexor to the abdominals into the pec into the cervical flexors. If you have good motion in the anterior flexibility highway, that is going to allow extension moments. But when we get limited in any part of these structures, that can create a compensation due to the limitation through that particular flexibility highway. So I want to look and see what kind of extension we have, and at the same time, it's very important that I stretch the same side calf with the same side hip flexor, because if one gets limited in motion, it's going to affect the other and vice versa. So again, anterior flexibility highway promotes extension moments. We can get into something like the true stretch and get into a position like this to allow dorsiflexion to extend the hip, or you can take it up into a more advanced, higher level by getting more hip extension and reaching up. But it is critical that we get extension moments, because the majority of programs in the fitness and the rehabilitation industry promote flexion and not enough extension.
As a review, the anterior flexibility highway runs from the anterior tibialis north to the distal quadriceps. The quadricep attaches to the hip flexors that connect to the abdominals. The abdominals run northward and merge with the obliques, the pectorals, and into the cervical flexors. If the position of the arm is flexed and or abducted, the anterior flexibility highway includes the upper extremity. Having good range of motion of the anterior flexibility highway will enhance extension movements.
The posterior flexibility highway consists of the plantar surface of the foot that connects to the Achilles tendon. The Achilles tendon comes north and connects to the posterior calf group, particularly the gastroc and the soleus. The gastroc comes up above the knee, attaches at the femoral condyles posteriorly and laterally to the condyles, as well as medially to the condyle. And it forms this connection of the gastroc to the hamstrings, what I call the trapeze arteries of the body. The hamstrings come north, attach at the ischial tuberosity. Via the sacrotuberous ligament, will connect at the sacrum, conjoin through the lumbar fascia, up through the erector spinae to the occiput of the skull, coming through the epicranial fascia to the forehead. If you have good flexibility highways in the posterior flexibility highway, that will enhance a flexion moment. Anytime that any of the structures on the posterior flexibility highway become limited in motion, that can create a compensation and limitation through the entire posterior flexibility highway chain. So we can stretch hamstrings, but remember, we have to stretch the calf, we have to stretch the hamstring, we have to stretch the gluteals, we have to stretch into the erector spinae, and then it's even going to branch off into the lats, into the shoulder, if we want to look at it that way, into the posterior cervical flexors to allow this entire flexibility highway chain to promote flexion.
As a review, the posterior flexibility highway begins at the plantar fascia, connecting to the calcaneus to the Achilles tendon. The calf group runs from the Achilles north with the gastroc attaching at the femoral condyles. The gastrocnemius attaches with the hamstrings that attach below the knee and wrap around the tibial condyles. The convergence of these tissues form what I call the trapeze artist of the body. The hamstrings run north and attach proximally at the ischial tuberosity via the sacrotuberous ligament attached at the sacrum. These tissues merge with the sacral fascia, meeting the lumbar fascia, and connect distally with the erector spinae. The erector spinae travel north and proximally attach to the occiput, to the cranial fascia, to the forehead. Good range of motion of the posterior flexibility highway enhances flexion moments. These photos are taken from Thomas Myers' Anatomy Train's second edition. Notice how the fascia all connects. Notice in the middle photo where the gastrocnemius and the hamstrings converge. Notice the longitudinal relationship from the foot at the plantar aponeurosis up to the epicranial fascia.
The most overlooked flexibility highway is the lateral flexibility highway. Lateral flexibility highway goes from the perineals up to the iliotibial band to the tensor fascia lata, the medius, glute minimus, and the quadratus lumborum, conjoined with the intercostals, the obliques, into the lat, into the rotator cuff, even into the tricep, and depending on which way you hold your forearm, can affect the forearm. Enhancing the lateral flexibility highway will enhance frontal plane motion and hip adduction, which is absolutely critical for hip function, for back care, but also to allow the hips to internally rotate. You'll have limited internal rotation if you cannot adduct and rotate versus a hip that is tight and trying to rotate. I often see people who are tight in the lateral flexibility highway develop some back pain. I see runners, cyclists, swimmers that are often tight in the frontal plane. I see the sedentary population, the elderly population. I see people who have had foot and ankle problems, knee problems, hip problems, shoulder problems start to lack frontal plane motion through the hip. It is absolutely critical for optimal function. It's critical to help keep the back and the low back healthy, to keep the shoulders healthy, and also to allow the body to function in all three planes of motion by enhancing the lateral flexibility highway.
To enhance lateral motions in the frontal plane, there must be ample range of motion along the lateral flexibility highway. Starting at the perineals, traversing northward, there is a convergence at the lateral fibular head with the fibers of the iliotibial band at the lateral tibial condyle. The iliotibial band continues upward to conjoin the tensor fascia lata. The tensor fascia lata merges with the lateral gluteal complex, and as the lateral gluteals meet the quadratus lumborum, obliques, intercostals, into the latissimus dorsi, into the shoulder girdle, the lateral flexibility highway is crucial to allow not only adduction moments, but will improve hip internal rotation.
We have two X factors in the body. The anterior X factor goes from opposite hip to opposite shoulder, and the posterior X factor goes from opposite hip, the gluteal complex, into the opposite lat. Anytime that you have extension and rotation, you're getting a stretch through the adductors into the hip flexors towards the opposite oblique, into the pec, into the anterior shoulder. Movements such as throwing is an example. Movements such as grabbing and lifting. Movements such as a backswing in the golf swing where this is lengthening, the opposite hip and adductor into the opposite pec and shoulder that goes through the obliques is going to allow the anterior X factor to become lengthened. It's absolutely critical that we get the adductors stretched out in this case. And how we can possibly do that is getting into this position and rotating, or rotate the opposite way. So when we do so, you're able to get this extension and rotation. On the posterior side, if you look at the opposite glute goes from the lateral hip at the greater trochanter, comes up and converges with the lumbar fascia. You look from the lumbar fascia to the opposite lat,
you see that there's almost a direct parallel line that forms this X at opposite hip, opposite shoulder on the backside. Anytime that we go into flexion and rotation, we must go through the posterior X factor. Anytime that we've used up the available motion in the hip or the thoracic spine, the excessive rotation or the excess rotation that's needed to complete that task often comes through the lumbar spine. So it's very critical that we get those two factors to stretch together. And we get the anterior as well as the posterior stretch together. So a method that we can use to stretch the posterior flexibility highway is crossover. So now we're going to get a stretch on the right glute, reach across, and turn into the left arm so you see a stretch in the opposite lat and opposite glute. If we look at it from the backside, you're going to see that particular stretch. It's important to get both X factors, anterior X factor and posterior X factor.
When viewing the adductor group, the fibrous alignment run from the posterior femur medially to the pubis ramus. The fascia is a close neighbor to the rectus abdominis and external obliques on the opposite side. The external oblique meets the serratus anterior into the pectorals to the opposite shoulder. To allow efficient movement of extension and external rotation, the anterior X factor must be stretched together in order to get that motion from the hips and shoulder girdle and not from the low back. View the musculature of the posterior X factor from the back and notice the fibrous alignment of the opposite latissimus dorsi and gluteal complex. The posterior X factor has a parallel line along these soft tissue structures that converge through the lumbar fascia. Possessing good range of motion along the posterior X factor will improve movements requiring internal rotation of the hip and flexion.
The last and newest flexibility highway is the turnpike. The turnpike goes from the opposite posterior neck, from the scalenes and the cervicus capitis, down into the rhomboid, comes across to the spinous process to the opposite scapula. The rhomboids converge with the medial 30% or so of the rhomboid to the subscapularis on the medial side of the scapula. Subscapularis runs across about the lateral 20% of the scapula. The subscapularis converges with the serratus anterior, which then converges with the external oblique, coming down to the opposite hip. Anytime that we have to hold our arms stable, as an example, and reach underneath, you're stretching through the turnpike. Anytime that you have to reach up and look around, for instance, you may have a athlete who is running and has to catch something in this respect. You're seeing that we're connecting the cervical spine to the thoracic spine to the hips through the turnpike. The turnpike really works through rotation, but the turnpike is also greatly affected by having good frontal plane motion through the lateral flexibility highway. So when we do movements such as this and back, you're not only getting rotation through the turnpike, but if you notice, I'm also getting frontal plane motion and I'm getting movement through the lateral flexibility highway. So one depends on the other. Again, as a review, we have anterior flexibility highway, posterior flexibility highway, and the lateral flexibility highway. Two X factors of opposite hip, opposite shoulder, and the anterior X factor of the adductor hip and to the opposite shoulder, and the posterior X factor of opposite glute through the lumbar fascia to the opposite lat and the turnpike.
The turnpike connects the opposite posterior cervical spine to the opposite scapula, wrapping around the back to the same side hip. The scalene and the cervicus capitis attaches to the rhomboid to the opposite side of the spine. The opposite rhomboid connects to the medial 30% of the anterior surface of the scapula and merges with the subscapularis. At the lateral 20% of the scapula, the subscapularis conjoins the serratus anterior, which wraps around the side of the torso and unites with the external oblique. The external oblique fibers run diagonally to the opposite hip. The turnpike forms a relationship with the cervical spine to the hips especially when rotational actions are required involving the head, shoulder girdles, and hips. So when we look at the flexibility highways and we put this all together, here are some suggestions of what I do when clients present for either training or corrective exercise. All dynamic movements are done as part of a warm-up. So I'll perform a dynamic warm-up consisting of medicine ball wide rotations, figure eights, triplane lunges, over and under hurdle patterns, crossover patterns, and a brief cardio session if they desire. Then the training session takes place, and we emphasize adequate motion through the foot and ankle complex, hips, and thoracic spine. These concepts will be discussed further in program design. After the training session, clients will do their flexibility highways to allow stretching in the 6 flexibility highways, and to make sure the key relationships are stretched together, such as the same side calf and hip flexor, opposite hip, opposite shoulder girdle, and making sure we get adequate movement through the lateral flexibility highway. Flexibility Highways in Motion was designed to provide movement patterns to match the designated stretch of the flexibility highway. The rationale is to sensitize the proprioceptors and to provide eccentric loading of the soft tissue to control the increased range of motion. I have learned through my mistakes that if I have mobilized somebody but have not given them an adequate matching designated movement pattern to control that stretch, they have difficulty controlling that increased range of motion and have increased their risk of injury. Therefore, Flexibility Highways in Motion is necessary to help control the increased range of motion. Please keep in mind that the Flexibility Highways in Motion program goes from a remedial to a progressive pattern to allow our clients or our athletes or our patients to be able to slowly progress into more dynamic movements from a basic or remedial position. To start with, wall patterns are a wonderful remedial movement pattern that is designed to enhance motion through the foot and ankle complex and the hips in 3 planes of motion in a controlled environment. Notice that the line divides the body into right and left halves. Also imagine the numbers on a clock with 12 o'clock overhead and 6 below, which is the sagittal plane, 3 and 9 on the clock in the frontal plane. Notice movement to the 3 and 9 positions occurs through the hips and off the center line. This loads the lateral flexibility highway quite effectively. Don't think of the 6 and the 12 o'clock positions for only right hand, or the 12 to 6 o'clock for the left hand. We move in 3 dimensions. We move in a 3-dimensional environment. So we do perform actions to the opposite side. When the left goes right, or right goes left, notice how the motion is shifted through the hips and then the hips rotate. When rotation occurs, I cue my clients to think there's a flashlight in the navel, which I call the beacon of life. When doing rotational patterns, shine the beacon of life all around the room, because where the pelvis goes, the low back will follow. Start with 3 to 5 repetitions in each vector, perform 2 sets, and progress to from 1 to 15 repetitions. Progress from 10 to 15 repetitions, 3 sets. Ankle moves are extremely important. Anytime that we've had people who've had a foot or ankle problem, anytime people have had a hip injury or a knee injury, the ankle does not function properly. This movement pattern is extremely important for those who have had compromised ankle dorsiflexion. If ankle dorsiflexion is limited, the hips will lose range of motion, rotation will be reduced, and the functional actions throughout the body will be compromised. This is designed to enhance motion through the ankle, improve calcaneal eversion, tibial internal rotation, and forefoot abduction, all of which make up foot pronation. Anterior lunge with overhead sagittal plane reach. This movement pattern becomes more progressive. It is important the client has adequate strength levels, good motion through the ankle, hip, and thoracic spine. This is a lunge with an overhead reach to eccentrically load, gain strength, and proprioception in the anterior flexibility highway. If the client has significant kyphosis or anterior pelvic tilt, or shoulder girdle limitations, I do not suggest this pattern until these regions have better functional action and do not create limitations. Posterior lunge with overhead reach. This will load the anterior flexibility highway through a posterior lunge. It is critical not to take a long posterior stride, especially if the client has limited ankle dorsiflexion. This can increase the risk of injury to the Achilles tendon or lumbar spine. Start with a short stride, for example, about 1/2 of the foot length, then gradually increase the motion. If the client has significant kyphosis, anterior pelvic tilt, or shoulder girdle limitations, I do not suggest this movement pattern until these regions have better functional action and do not create limitations. The sagittal plane rotator cuff. This is a very dynamic action, or can be made more remedial by slowing down the movement or limiting the range of motion. This will eccentrically load the anterior flexibility highway and also eccentrically load the rotator cuff. Again, like the previous two movement patterns, if the client has significant kyphosis, anterior pelvic tilt, or shoulder girdle limitations, I do not suggest this movement pattern until these regions have better functional action and do not create limitations. The overhead med ball toss is a very dynamic action for the anterior flexibility highway. Do not do this with clients with low back pain, lack of ankle dorsiflexion, or shoulder impingement issues. Make sure the motion comes through the hip and not through the low back. For the hip to be able to extend, remember we must have good ankle dorsiflexion to allow that motion to occur. Even though crawling progressions are categorized in the posterior flexibility highway, this really affects the anterior flexibility highway as well. Do not overlook the effectiveness of crawling patterns. It allows a contralateral coordination of primal movement patterns. This action loads both the posterior flexibility highway and the anterior flexibility highway. With long reaching, it can even impact the X factors. Be cautious of those that cannot place pressure upon their knees. Once again, wall patterns can be used not only for the anterior flexibility highway, nor the lateral flexibility highway, but it can also be effective for the posterior flexibility highway, particularly when going into the 6 o'clock or squatted position. Wall patterns are very remedial, but they greatly impact all 3 planes of motion and all 6 flexibility highways. The anterior lunge with knee height reach is an effective movement pattern that will strengthen the lower extremity as well as the back. The anterior reach at knee height will eccentrically load the posterior flexibility highway and all the back musculature. If knee height is too advanced, have the client reach forward at shoulder height, then chest height, waist height, hip height. The verticality will add to the progressive sagittal plane demand upon the system. Frontal plane lunge with knee height reach. This movement pattern has the same rationale as the anterior lunge with knee height reach, except with a frontal plane influence. If a posterior X factor is desired, reach the opposite hand to the opposite knee. Use the verticality principle to increase the demand upon the system as you move shoulder height downward toward lower levels. We discussed the principles of the sagittal plane rotator cuff to affect the anterior flexibility highway. But as the client goes into a flexion moment, it will be affecting the posterior flexibility highway as well. Remember, if there is significant kyphosis, significant anterior pelvic tilt, shoulder impingement, or even the inability to get into ankle dorsiflexion, I may wait on this movement pattern until these movements have improved. We discussed wall patterns earlier of how they can be very effective in all three planes of motion, particularly when you reach from the 3 o'clock and the 9 o'clock positions, as well as opposite arm to the opposite side reach. Wall bangers are very effective and yet a remedial movement pattern. Essentially, this is a rotational squat that is performed in a controlled environment that is effective for the sedentary population, people in post-rehabilitation, or beginning fitness clients. This helps to mobilize the foot-ankle complex, hips, and shoulder girdle, strengthens the lower extremity, and yet will lengthen the lateral flexibility highway, posterior flexibility highway, and posterior X factor. The frontal plane lunge with opposite overhead reach will strengthen the lower extremity and hip complex during movements in the frontal plane. When adding the opposite overhead arm reach to the movement, the lateral flexibility highway is eccentrically loaded to lengthen the soft tissue while providing strengthening phase to this action. This will effectively improve mobility in the frontal plane. Type 1 and Type 2 thoracic spine mobilization. Motion in the thoracic spine occurs simultaneously in all three planes of motion. The two actions of the spine are Type 1, when the spine rotates in one direction while it laterally flexes in the opposite direction. And Type 2 thoracic spine actions occur when the spine rotates in one direction and laterally flexes in that same direction. The majority of daily actions involve Type 1 thoracic spine motion. For this action to be successful, there must be ample lateral flexibility highway motion. Doing this activity will also impact the anterior X factor and the posterior X factor. The following videos will demonstrate movements that are effective to gain range of motion and stability through the anterior X factor. Some of these actions have been described for other flexibility highways, yet are very useful through the anterior X factor. The crawling patterns and the wall patterns have been discussed earlier for all three planes of motion, but now envision how the tissue is reacting through the anterior and posterior X factors. Type 1 and Type 2 thoracic spine mobilization will enhance anterior and posterior X factor motions. The triangulated shoulder press crosses all flexibility highways. This can start with only the use of arm motion and then progress with the use of dumbbells. Be cautious of how much weight the client will use as they progress, because the further away from the midline the movement is, the greater the forces upon the shoulder girdle and throughout the system. The anterior X factor and posterior X factor are affected when the client presses or reaches to the same side or opposite side rotational reaches. The lateral flexibility highway is affected with the same side lateral and opposite side lateral reach. The anterior flexibility highway and posterior flexibility highway are impacted with anterior and posterior reaches respectively. If a client has kyphosis, significant lordosis, or shoulder impingement symptoms, I suggest avoiding the posterior overhead press and get the motion through the rotational pressing actions. Transverse plane lunge. As the rotational lunge occurs, make sure the trail leg pivots so the rotational motion of the arms does not cause excessive rotation through the lumbar spine. By pivoting on the trail foot, the pelvis will rotate and action will go through the hips and thoracic spine. Remember, where the pelvis goes, the low back will follow. A star lunge. Make sure the motion comes through the pelvis and the hips. If the hips are tight and the client cannot get good hip extension or significant lordosis is present, do not do this movement pattern as the risk of the increased extension through the lumbar spine exists. I often use this exercise with an ankle cuff band attached from one ankle to the other to get more strength through the gluteal complex, especially the lateral gluteal complex. But this can be effectively done without an ankle cuff or even without dumbbells. Power poles are a very high level activity. Notice that the angles of the elbows and shoulders do not change appreciably. The movement initiates through the hips. If the hips are immobile, improve the range of motion in the hips prior to attempting this exercise. This is extremely effective for increasing strength through the hips, range of motion through the hips, and also the abdominal complex. Our next module is functional assessment, which will explore the techniques to evaluate the limitations, compensations, and idiosyncrasies of clients to determine how they move in 3 planes of motion. Often these assessment tools unravel the complexities within the body to explain overuse issues and provide the data for a true personalized exercise prescription and program design.